The most common thing I hear after knee replacement is, why didn't I do this sooner? But there's another conversation I have in clinic just as often. It's the one where I talk somebody out of having a knee replacement, or at least out of doing it right now. Because not every painful knee is ready for a replacement. And historically, as many as 1 in 5 knee replacement patients aren't fully satisfied after the surgery. So today, 2 questions. Who should not get a knee replacement yet? And number 2, why do some knees disappoint even when the surgery goes fine? Let's start with the first question. Somebody hears the word arthritis and their brain jumps immediately to knee replacement. And I get why. Knee replacement is the only cure for knee arthritis. Same for the hip. But the only cure doesn't mean it's the next right step. There are good non-surgical treatments for the symptoms of arthritis, and surgery should always be a last resort. And that's a surgeon telling you that. Arthritis comes on a scale, like a tread wearing on a tire. 10,000 miles into a 15,000 mile tire, you don't replace the tire. There's still good function in that tire. That knee. There's still good life. I walk through the whole non-surgical menu in my arthritis video, so I won't repeat it here, but go check it out. But here's the part I want you to hear. The research backs this up. When knee replacements are done on people with less severe arthritis, the outcomes tend to be worse. Patients with milder arthritis on x-ray end up with more pain after the surgery and more dissatisfaction. Why would that be? Because arthritis causes pain, but so do a lot of other things. Tendinitis, bursitis, a meniscus tear. If you replace a joint for all joint pain, whatever else that may be hurting may still be there. And obviously that patient's not going to do very well. The patients that do best with knee replacement have severe arthritic disease. Now, the x-ray is not the whole story, and it never should be. Your function matters. Your quality of life matters. 2 people with the same x-ray can have very different plans, but severity on x-ray does correlate with how happy you'll be afterward. That's worth sitting with, especially if you're one of those with arthritis that on x-ray is mild. Let me make that real. A 52-year-old gentleman came to see me, this is years ago. His primary care doctor had ordered x-rays and an MRI. And yes, the MRI report did say some arthritis, and that was certainly true. But when he came into my clinic, I got standing x-rays of him. And when I looked at the cartilage loss, it was maybe 10% of his cartilage was lost. So very mild arthritis. What the MRI did show, in addition to this very mild arthritis, which is what he picked up on, was a significant meniscus tear. It was the meniscus tear that was hurting him. So we didn't replace the knee, we scoped it. A 20-minute procedure, 2 days on crutches. I ran into him socially just the other day. Now this is 5-6 years out from his surgery, and his knee is still going great. So he didn't need a knee replacement. Now, let me be careful here. A scope is no cure for arthritis, and that's important. But for the right person, if you have a meniscus tear and mild arthritis, a scope can be the right call. Here's the other one that fools people, the hip joint. Let me tell you this story. A 72-year-old lady came in to see me for severe knee pain. My team actually x-rayed her knee when she was checked in, so before I even saw her. And the x-ray did show some mild arthritis in her knee. But her exam, no swelling, normal motion. But when I moved her hip, that's when the knee really hurt. So I sent her back to the x-ray department for x-rays of her hip. She had severe hip arthritis. Now, she had trouble believing me because she felt all her pain in her knee. So we did a steroid injection into her hip joint. For a week afterwards, she had no knee pain at all. That's what convinced her. So eventually, she had her knee replaced. Now, that was about 10 years ago. I see her for routine follow-up. No hip pain because of the hip replacement, and no knee pain, even though her x-rays showed that mild arthritis years ago. Severe hip pain can send all that pain to the knee, so you got to be careful. Some people with a bad hip only feel it in the knee. You got to be careful. This, and for a lot of other reasons, you need a full evaluation before you replace anything. Okay, now on to question 2. Why do some knees disappoint? Here's the historical number. and I won't hide from it. In the landmark research here, as many as 1 in 5 knee replacement patients after surgery was not fully satisfied. In practice today, I think we're better than that. We have better implants, better pain control, and better recovery protocols. Most estimates nowadays would say unhappy patients are maybe 1 in 10. In my practice, I think it's even less than that, at least I hope it is. But I won't tell you that number's 0 because it isn't. A knee replacement fixes arthritis. It doesn't fix everything that can hurt around a knee. You can still have swelling, tendinitis. Obviously with surgery, there are risks and complications. And sometimes you have a knee replacement that works initially, but it can fail completely and mechanically and has to be redone. So what separates the happy knees from the disappointed ones? The biggest driver is actually in your control, and it's expectations. The research here is consistent. Unmet expectations are the strongest predictor for you to have an unhappy knee. If you go in believing this is an outpatient procedure and you'll be back at work with 2 days, no restrictions, you are likely to be disappointed. Now that can happen, but that's not the expectation you should have. So here's my expectations conversation. This is what I actually tell my patients. A knee replacement is best at taking away the pain. It's next best at improving function. And it's third best at improving your ultimate range of motion. So relieving pain, improving function, better motion, it's in that order. My goal for every patient is all 3, no pain, optimal function, full motion. But they tend to come in sequence and your priorities matter. So how do I spot a knee that's likely to be disappointed post-op? Here are the red flags that I watch for in a clinic visit. 1, arthritis that's mild on x-ray, especially when it's attached to a big pain story. That mismatch means something else may be driving the pain. Number 2, expectations that don't match the operation. Back to work in 2 days guaranteed, back to full running at 2 weeks. Dangerous expectations. The third red flag, pain that the exam can't localize to the joint itself. So no swelling, good motion in a knee that looks quiet, but the patient says it hurts. That's when I start looking at other things like the hip, tendons, and the spine. Also, I worry about a knee that hasn't tried anything else yet. So no therapy, no activity changes, no injections. Surgery shouldn't be the first thing a knee tries. None of these red flags means never have a knee replacement. It just means maybe not yet. Let's figure out what the real problem is first and then start treatment. And motion after a knee replacement follows a rule that I think you should know before surgery. The stiffer you are going in, the more likely you are to be stiff coming out, which means you can actually wait too long. Waiting longer can complicate your recovery. So there's a balance. You don't want to go too early, but not too late either. I have a whole video on knowing when it's time for surgery. The short version is you'll just know. Now, the thing that bothers me in this space, it's when somebody is told you have arthritis, replacement is inevitable, so you might as well go ahead and get it done. That's not how this works. Surgery is a big decision. It has to be individualized. Mild arthritis deserves non-surgical care first. And before a knee replacement, you and your surgeon should be able to say 3 things together. The disease is ready, the expectations are realistic, and you're optimized as strong and as healthy as you can be before a major surgery. That's how you end up in the happy group. The group that says, why didn't I do this sooner? If you've already had a knee replacement and you're in the disappointed group, don't just live with it. A disappointed knee deserves answers. Sometimes it's the tendons. Sometimes it's the hip. Sometimes it's the back talking to you. Sometimes it's the implant itself. And some of those problems are fully fixable. Get evaluated. Ask questions. An unhappy knee is a question to answer, not a sentence to serve. There's a companion article that goes a little bit deeper on everything I've said here. It's linked in the description. If you're weighing your own decision and you want to talk it through, there's a scheduling link down there too. And ask questions in the comments. I read them all and we'll get to them. Thanks for watching.